Good evening. We want to welcome you all to UOA On Demand. Our goal is really to bring you, the patient, a group of orthopedic surgeons, and provide you with an in-depth look at a common problem that we treat in the office. And really have a discussion about that clinical problem, talk about the diagnosis, the imaging, and the treatment options that we have for that problem. I think a lot of times many patients sustain an injury and they're left searching the internet, and we really want to provide this information for you. We certainly consider ourselves experts in this field, and we try to provide really state-of-the-art and evidence-based treatment to you, our patients. And I'm certainly honored to be joined by two of my colleagues and partners tonight, both experts in this field. My name is Patrick Buckley. I'm a sports medicine orthopedic surgeon here at UOA, and I'm going to function tonight as our moderator. I'm honored to be joined with two outstanding people, as well as surgeons, and we're going to talk about the topic of Achilles tendon ruptures. First is Dr. Kenneth G. Swan, who is an orthopedic surgeon and sports medicine specialist here at UOA. He did his training at UMDMJ, as well as a fellowship in sports medicine at the University of Colorado. And I'm also honored to be joined by Dr. Justin Fleming, who's a board-certified foot and ankle surgeon, and he trained at Emory for his foot and ankle surgery, as well as within the U.S. Army at Fort Benning, as well as in Europe. So welcome to you both.
Hey, thanks, Patrick.
So, without further discussion, I certainly want to dive right into it. It's a common problem we see in the office with the topic of Achilles tendon ruptures. So, Dr. Swan, talk to me a little bit about what you see and what you're listening for in the history of someone who you are concerned about an Achilles tendon rupture.
Well, thanks, Pat. Achilles tendon ruptures are not that difficult to diagnose. And the reason for that, compared to some of the other things we see, is that the history is typically pretty classic. Most commonly, this is what we might call a weekend warrior, someone in their 30s, 40s, could be in their 20s, who's out and about on the weekend playing their sport, whether it be tennis or basketball or maybe hiking, and something happens where they think they were struck or kicked in the back of the leg, and they have pain there, and they turn around and there's no one there and no one hit them, and all they know is that their ankle isn't working quite right and they're having some pain. And they can often limp off the court, sometimes not. But it's the back of their ankle or their heel that's bothering them, and they get to medical care pretty quickly because they know something's not right. Sometimes they think it's a sprained ankle, but the history never really dictates that. The history will tell us that, hey, they snapped their Achilles. So it's usually in that history we know, hey, we got to look at that Achilles based on their age, based on the mechanism they just described. And then we go to the exam, of course, but usually you sort of know walking in. But on the exam, the patients typically have a swollen ankle. It typically gets black and blue or ecchymotic. And on palpation, you can feel a defect in the Achilles, the heel cord right behind your ankle. You can palpate an actual defect in that cord, and it's tender right there. And then usually we will have the patient lay on their stomach in the prone position, and we do something called the Thompson test, where we squeeze the calf to see if the foot reacts the way it should or the way it does on the normal side. And that's one of the major diagnostic exams we do to confirm that there's an Achilles rupture.
Perfect. Yeah, it's obviously a very common thing, and it's an interesting thing when someone believes there's somebody behind them with a baseball bat, but then they turn and they look and nobody's ever there. So Justin, what do you think? Is this something that, you get an MRI in every one of these patients? Is this something that you kind of go off of clinically? Talk to me about any imaging you may think about.
Yeah, so I think this is definitely an area of debate, and the question is whether or not an MRI is necessary for the diagnosis or the treatment. And as KG said before, it's definitely not necessary for making the diagnosis. This is relatively clear in terms of what it is. The question becomes then, what's the spectrum of Achilles injuries that could present in a similar way? And so there are generally two different types of Achilles ruptures. And one is the common rupture that we see with Kobe Bryant and Kevin Durant and Richard Sherman, kind of these what we call mid-substance ruptures that happen just behind the ankle joint. And then those are the most common. And there's a smaller subset of Achilles injuries where the Achilles actually will essentially avulse or tear off the bone, and those are called sleeve avulsions. And those patients typically will have symptoms, what we call prodromal symptoms, or symptoms for a long period of time, and essentially the tendon undergoes degeneration and then ruptures. And so those two things, even though they're both surgical in nature, they do have different ways that we treat them operatively and post-operatively.
Sure. I think that's something we'll dive into as far as the operative treatment, but differentiating that, the mid-substance versus the insertion, I think is something that, physical exam-wise, we really look at, because it does change what we do. And if you're talking about fixing these, you got to know that and know where you want to go to take care of that injury. So, one other thing I want to just maybe bring up that came to my mind is that a lot of times this can be confused, or there can be another common injury in kind of the back of the calf, a plantaris rupture, which sometimes patients can feel a very similar event and a similar history. So, KG, how do you differentiate that? What are the things that maybe a patient would look at for a plantaris rupture that would be different than an Achilles?
Yeah, I think that's a good point. I think both plantaris as well as just a medial head of the gastroc strain, which can both present acutely like that. They may hear or feel a pop in a similar way and have pain in the calf somewhere or down by the foot. But the plantaris tends to not get quite as ecchymotic, and then they don't have that defect in the Achilles, nor do they have that abnormality in the Thompson test. So if you thought you tore your Achilles and you ended up with a plantaris injury or a gastroc or calf rupture or strain, that's a good thing.
Agree.
That it is. Yeah. Yeah, I had one of these when I was in medical school, and it was a plantaris rupture, and I was very thankful when I, actually realized that's what it was. So, Justin, talk to me if someone presents in the more chronic setting. First of all, what do you define as chronic for this, and then how does that change what you might talk about with someone who, presents in a more delayed fashion and had this, a couple months ago, and is now seeking treatment? What does that change for you?
Well, it changes a lot because, I guess to first answer your question, I think when we talk about chronic, it probably is over the 4 to 6 week mark. I think that's really when we have to start thinking about different options for these patients. If you see them further on down the road, unfortunately, the conservative management option of kind of treating these patients in a cast or in a wedge boot, basically it goes out the window simply because the tendon ends are so far apart from each other that they really just don't have the ability to mend. And so when you see these patients, and often it's time, it happens if they have a delayed presentation to, an urgent care, or perhaps there's a lapse of insurance. That's kind of when we start to see these patients because they're rarely misdiagnosed. But unfortunately, at that point in time, an MRI would be mandatory to try to evaluate how far the tendon ends are apart, and then what do you need to do surgically to get those, to reestablish the Achilles tendon itself.
Sure. This is, I think, an area in orthopedics where we have a lot of great data to go off of, right? There's a lot of really good studies comparing treatment options. So, could you talk to me about what you kind of, go through when you're seeing somebody who has an Achilles tendon rupture? We've diagnosed it, we've done the exam, and now we transition to what do we do for that patient? What are the big picture options? And specifically, I want to have you talk a little bit about your protocol for, non-operative treatment and kind of what you like to do for that.
Right. So I agree. This is an area where we do have good literature to help guide our decisions or support the decisions we make. Either way, you can treat an Achilles rupture non-operatively. I think many people have started to understand that, but for many years, nobody really knew that. Years and years ago, that was an option. People would be put in either a long leg cast for a long period of time and on crutches for weeks and weeks and weeks or months, and that was a treatment option. Surgery, of course, was an option too. The difference between the two was really the risks. What are the risks of those two? So the risk of treating this non-operatively in the past was that if you locked someone up in a cast for a long period of time, their tendon does heal. The majority of the time it does heal, but it has a higher rate of re-rupture when the athlete gets back to their sport, basketball or tennis or whatever it may be. However, surgery has a known complication risk. Most commonly, infection or skin problems around that surgical wound is a known complication that certain people need to avoid. So that was sort of the dilemma years and years ago. I say it like it's a long time ago, back when I was training. Unfortunately, nowadays that's years and years ago. However, in the past 10 years or so, a non-operative treatment protocol, including early range of motion and early weight bearing, instead of locking them up in a cast for a long period of time, has shown to decrease that re-rupture rate. So the patient can heal their tendon without surgery and have a relatively low and an acceptable re-rupture rate that you can avoid surgery. Now, who would that be, to answer your question? It definitely depends. And this is a very gray area, or something you could really open it up for debate. But there's certain patients who you sort of want to avoid surgery on. There's certain people who are at risk for that complication of infection. That might be your diabetics, your very heavy smokers. There are people who just are not good operative candidates. And those folks, I would lean strongly towards the non-operative protocol. Whereas, and perhaps Dr. Fleming will agree here, the athlete who needs that explosion out of a stance, the very young athlete who tears their Achilles, those folks are much more likely to lean towards surgical intervention.
Sure. Yeah, Justin, why don't you kind of maybe give us your take on that as well?
Yeah. So I rarely ever agree with KG, but I'm going to give him this one. So I agree. We've definitely, had this issue of wound healing issues, of nerve injury, of infection, all associated with open treatment. And I think, like anything that we do, we start to see trends over time. And that's essentially because we get really excited about something, and then we look and say, well, maybe it doesn't work as well as we thought. And then we're kind of back to square one, which is cast immobilization or this functional rehab. There have been advances like in other parts of orthopedics in Achilles ruptures. And so now we're in a generation, or in an age of minimally invasive surgery. And so by operating on Achilles tendons in a minimally invasive way, we're potentially taking away a significant amount of the downside and still providing the upside. And so this then changes the balance, because now I think that we can offer operative repair where the risk is lower than the benefit to a wider range of people. And I think that's still, we're still going to debate that till the end of time. But this is a new wrinkle and a new option that we have to offer patients.
Yeah, I think that's certainly something that in the last, 5 to 10 years, I've seen a lot of that for professional athletes being used. And if you can minimize risk but still get the benefit of, a repair, and especially the tension on that tendon, right? So this is something we talk about with having the tension correct on the Achilles tendon. It may heal, but if it heals elongated, you may not have that spring mechanism and kind of that explosiveness of your Achilles that is really important for a lot of our athletes. So, what is that minimally invasive surgery? Maybe talk us through what you like to do and kind of the steps of that type of a procedure. I'll give that to Dr. Fleming. Yeah.
Yeah. So if I could just back up, Patrick, and just try to give the audience the size of the magnitude of this injury. If you look from 2011 to 2015, there were 46 players in the NFL that were diagnosed with Achilles ruptures. And essentially 24 of those elite athletes, best athletes in the world, never played football again. So this is a really big deal. It's a big problem, especially in the sports world. The average NFL athlete that gets the Achilles repaired gets back on the field in about 10 months. And so again, just really, it's a significant injury in terms of rehab. Surgically, if I have stopped doing open Achilles repairs probably 7 or 8 years ago. If you look at the studies looking at open repairs, the traditional repair versus minimally invasive, essentially minimally invasive wins out because we're still able to restore the myotendinous, or the tendon length and the muscle length, and restore that push-off power that you talked about. But the complications come way down. And so this is a conversation I had today with a patient, 50 years old, plays in an adult soccer league, and has an Achilles rupture. And certainly in the past, that may not have been someone I would have offered the surgical option. But using this technique, I think it's very reasonable. I think there's less downtime for patients. And we're definitely in a society where we want things to happen quickly. And so if you're a plumber and you need to get back to work because you're the only person providing finances in your household, again, this is not the elite athlete, but still critically important to getting patients back sooner.
Sure. Yeah, I think it's very humbling when you have that discussion. A lot of patients sometimes can be surprised with the timeline to fully get back. And these are injuries that are not a 1 or 2 month turnaround type of a thing. They really do take that amount of time to get back. And these are the professional athletes. I think it's an important discussion to have when you're talking with patients about the timeline it's going to take to fully feel comfortable and feel confident in that Achilles. So, Dr. Swan, talk a little bit about your kind of protocol with progressing someone if you are going to treat them non-operatively, and what that looks like for them, from a splint or a cast to a brace. Like, what does that look like? If you can kind of walk us through that.
Yep. But both my non-operative and my operative protocols are relatively similar, but sort of ironically, I gauged my post-operative protocol comes from the non-operative protocol, which we've now deemed safe to start early range of motion and early weight bearing after these injuries. So basically, someone comes into the office after a couple days after their injury, they may have gone to an urgent care and they may have a splint on. But my protocol starts like the day I see them. Okay, the day I put them in the splint, the proper splint. So day one, they're put in a splint behind their ankle in the position of what we call equinus, meaning their foot's pointed down. And when we do that, that helps bring the tendon edges back together instead of when the foot's flexed up, it sort of stretches out that Achilles. So they're put in that equinus splint for 2 weeks on crutches. Okay, they come back at the 2-week mark. I take them out of the splint, put them in a boot, a Cam Walker boot that we've seen a lot of people around town wearing. In that boot, they have a heel lift that still keeps the foot pointed down a little bit. Okay, they're allowed to start putting weight on it then at the 2-week mark. They're using crutches, but they're partial weight bearing at that point. Very importantly, part of the protocol and part of what a lot of the studies show is that right now is when we start early range of motion. So on their own, they don't even need a therapist for this. On their own, they sit over the edge of their bed and they just move their ankle up and down several times an hour. Take the boot off, move their ankle up and down, put it back on. We do that throughout the day. Very simple range of motion to help restore the tendon alignment for this non-operative protocol. That starts at the 2-week mark. They come back at 4 weeks. We reevaluate them and we let them weight bear at that point, no crutches at all at the 4-week mark. At 6 weeks, the heel lift comes out of the boot. And at the 8 to 10 week mark, they're out of the boot. The first 4 weeks of this, they're wearing the boot all the time, including at night.
Sure. Yeah, and I think it's important to stop and just give some perspective of how this has kind of evolved, because even in the recent past, I mean, most patients would be in that equinus splint for how long? Usually at least 4 to 6 weeks, where you would just have your foot completely pointed down, non-weight bearing, and that is a completely different life experience for 6 weeks on crutches versus being able to weight bear, being able to range your ankle. That's a huge kind of change in somebody's experience with this.
Totally agree. It's a real shift in how we treated them over the years.
Justin, talk about when you start physical therapy with someone you're treating non-operatively. Is that something you're waiting for any sort of healing? And what is the progression and the role of PT for that patient?
Yeah, so there's definitely a couple different stages for the first 2 weeks. The patient's off of it completely. Oftentimes, in the first 2 weeks, patients really don't want to walk. I like to protect the wound a little bit. And then at week 2, they get their stitches out. They go into a boot that has essentially a high heel in it or wedge in the back. And that allows them to walk. And by putting their foot in a downward position, it takes pressure off of the repair site. They can at that point ride a bike without tension. They can get back in the weight room. If they're lucky enough to have a 0G, treadmill, they certainly can start to walk and increase their amount of body weight. By week 4, they're flat in the boot. And then by week 6, they're in a sneaker with a heel lift. And I think the real key between week 6 and 12 is really not to overstretch the Achilles. So I'm just really cautious about kind of dorsiflexion or bringing the foot back up to the top side of the ankle, because I do think they can stretch the repair. And for a lot of these athletes, having a little bit of a tight Achilles is more of an advantage than having a loose Achilles. By 3 months, they're able to run, accelerate, decelerate, and then basically the trainers will take it from there. It depends on their sport, depends on what position they play, but often we'll release them without restrictions somewhere around the 4-month mark.
Yeah. I just want to talk about like your kind of outcomes. So, when you start looking at the outcomes of this and the success rates, what are you quoting to patients, and how are you using those outcomes to kind of guide who you're choosing to do surgery versus to treat non-operatively?
Yeah, so it depends what their goals are. As I mentioned in the beginning, we talked about the history with Achilles ruptures. This doesn't typically happen to teenagers or 20-year-olds. We see it in the pros and some 25-year-old running backs, but it most commonly, this is someone in their late 30s or up into their late 40s, and a lot of these folks just happen to be playing in a weekend softball game and they tore their Achilles, and they may not have really high expectations in terms of turning back into that elite athlete. If they are the elite athlete, that's a different story. We're trying to get them back, sooner and back to their exact, level of competition and not lose a step. So from a numbers standpoint, there's a few things to talk about. One is in terms of how we make our decision, what are the risks? So the risks, I mentioned infection, and I mentioned re-rupture. Both of those are now well under 10% with the way we do this. Really like to say under 5%, but if you're that 1%, it's still a terrible problem for you. So we really try and avoid those, of course. So got to pick your patients wisely. But somewhere around 5% chance for a re-rupture if you treat this non-operatively, much lower if you treat it operatively. But there is a infection risk, I would say somewhere around the 1 to 2% chance when you operate on the patient. Certainly when you do it open in the more traditional incision technique. So that's some of the numbers I think you were asking about, Pat, in terms of timeline for return to play. Was that part of your question as well?
I think it was. Yeah. I mean, we can go back and do it, but it's a good topic. Why don't you bring it up?
It is now, KG.
Yeah. So I find that patients with Achilles ruptures, well, to touch on what Justin said, he mentioned the 6-week mark where he's got to sort of, sounded like he says he's got to slow them down a little bit. And I agree. At about 6 weeks, 8 weeks, they're feeling really good. They don't have any pain. And they almost feel like they can, get out there and test it. But it's not quite ready. And I'm a little worried that when re-ruptures occur, it's sort of in that still early phase. So other than that, I find that many athletes still are cautious to get back, certainly after the non-operative protocol. They're cautious, and they typically wait till the 6-month mark or so till they really test it back on the hoop court.
Yeah.
And I'm fine with that. I think waiting until 6 months is a-okay if this is that type of patient. When we're trying to get them back on the the Olympic field, then we're pushing for earlier than that.
Sure. I want to switch gears a little bit because I think we don't talk a lot about prevention with a lot of injuries we see and things that we're talking about treatment. But one of the questions I get very commonly in the office is like, what's the role of stretching for preventing an injury like this? And I think I want to have you guys both talk about that, but also I think we're starting to see more and more the role of hydration to prevent like muscle strains and tears, these type of things, because a lot of the elite athletes are really focused on this, but these are lessons that I think can be applied to your weekend warriors at preventing these type of injuries. So what do you think from a prevention standpoint matters from an Achilles tendon rupture standpoint? Justin, I'll go to you.
Yeah, so I really don't know the role of stretching, to be honest. But there has been some association with fatigue. So fatigue in players that are either playing long tournaments, or was a Golden State Warriors player that had an Achilles rupture after a long series. So the question of whether or not that tendon is becoming overstretched and then the muscles are reacting late because of this, potentially that plays a role. Certainly you mentioned hydration. I from a physiological standpoint, that makes a lot of sense. I just don't know that we have the literature. I mean, there's some really good ideas out there, but I don't know that there's truly anything that prevents these injuries from occurring.
I agree. Regarding the hydration, it makes sense, but we're sort of looking for better data as far as that goes. I do think that some of these athletes are a setup. If they race from work and change into their softball gear in the car and run out onto the field and then trying to stretch a single into a double, should we be surprised that they pop their Achilles? So did they need to stretch? Does stretching really prevent that? There may not be great literature on that, but I do think adequate warm-up makes sense for a whole host of reasons. And so many of the high schools I cover, the colleges, have gotten a little bit away from the static stretch before the game or at halftime, sort of the one where you see the kids trying to touch their toes and it's like 30 degrees out and everyone's frigid and stiff. That's probably not the best way to prepare to get back on the field, right? Really a dynamic stretch and a warm-up before they get on the field, or certainly before that weekend warrior, 50-year-old softball player gets out there. You ought to run around a little bit and warm those muscles up, I think, beforehand.
Yeah, we used to call it getting a good lather in high school basketball. Our basketball coach used to say, you gotta get a good sweat going, you gotta get some lather, otherwise you're kind of not ready to perform. And certainly I think it intuitively makes sense. You have a little higher injury rate with that. So great. It's a tough one because I don't know what the right answer is, but especially with the current landscape of a lot of high school and recreational sports going back in a pretty short timeline, these are the things I think we have to think about to try to prevent them, because if you take relative inactivity with coronavirus, then you take a pretty short accelerated return to timeline, that's a recipe for injury. So I think those are the messages we're trying to get out there to hopefully prevent these injuries and give the audience tools to work on that and ultimately prevent anything from happening.
I think what's interesting, Patrick, is that the majority of these patients have had no previous Achilles symptoms, right? It's not like this is an area of their body that they've re-injured multiple times. This is generally their initial primary injury that occurs.
Yeah.
So it makes it a little bit more difficult to figure out why.
Yeah. So I'm going to put you on the spot a little bit. I want you to kind of give maybe your overall treatment recommendations in summary, but I want you to try to do it in about 30 seconds. So I'll give that to you, Dr. Fleming, first. But if you're talking to someone and you're trying to summarize how you approach a patient with an Achilles tendon rupture, talk to me, how you do that.
Yeah, I think in 30 seconds in this current day and age with the technology and surgical advances we have, I like to put the tendon back together. I think it's a definite to restore that myotendinous length, the push-off power. I think we can do it safely. I think the complication rate is low after that, and the satisfaction is very high. And I think we lose the downsides of potentially casting or non-weight bearing for a period of time.
Dr. Swan.
Well, I think Dr. Fleming wasn't listening to me because I don't cast these people. I let them weight bear early. So we can talk later.
I saw 5 patients in the waiting room with long leg casts.
So I really let my patients guide the decision making on this one. So, and it depends a lot on what their goals are, their age, and any comorbidities. If they have significant comorbidities, there's any sort of risk. If they're fearful of surgery for any major reason, they're really trying to avoid it. If the timing is not good for them, and who knows, with COVID or family issues or travel, sometimes it just, I can't do it, doc. I can't do this surgery in the next 2 weeks. Okay, well, we can safely treat you non-operatively because we now know how to. If you're a good surgical candidate, if you're a dynamic athlete, you're a young athlete trying to get back to a competitive sport, we're going to fix you and make that tendon what it was.
Yeah. Well, I think that's great. And, I certainly want to thank you both for your time tonight. This has been a lot of fun. Certainly, we look forward to more of these in the future. And I can promise you that our jokes are even better in person. So, if you have an injury and you are looking for great orthopedic care, we're certainly here and would look forward to taking care of you. I think you'll find at UOA that we all really try to treat you as if you're a family member and really, give you options and talk you through the pros and cons of those options. Certainly, you can find more information on our website, uoanj.com. As well as our social media platforms. But with that, we'll turn it over and we'll look forward to having another one of these discussions again in the future.